the most common misperception for triple-negative breast cancer is actually that it's one thing. It's very hard to define something by the things that it's not. Faulkner was a master at doing that, but that doesn't work so well in breast cancer. So triple negative just means it doesn't have the estrogen receptor, doesn't have the progesterone receptor, and it doesn't have HER2. It's a collection of a bunch of different diseases. I think of triple negative right now as sort of breast cancer's version of the kitchen junk drawer. We all have one. You throw in lots of bits and pieces that don't clearly fit someplace else. But there's not a common theme to what goes in that drawer beyond that. So a lot of the work now is starting to unpack that junk drawer, understand what's in there, what are the different subtypes, how do they behave differently, and we'll start to see over time how they might need to be treated differently. So I think the most challenging aspect right now of treating triple-negative breast cancer is that we don't know enough about it. We know that our targeted therapies, things like hormone therapy or anti-HER2 therapy, are not going to be effective. And that leaves us with chemotherapy as the mainstay of treatment. The problem with that is chemotherapy is a pretty blunt instrument. We don't really have a good way of predicting who is more likely to benefit from one chemotherapy or the other. And chemotherapy has substantial toxicity, so it's not really the therapy that our patients want. I think that makes the discussions for patients with triple-negative disease difficult because I just don't have the sort of therapy that they want and that they really need. So PARP inhibitors have been the most useful in patients who have a genetic BRCA mutation, both BRCA1 and BRCA2. The PARP inhibitors really take advantage of the inherent biology of BRCA mutated breast cancer. If you've lost function of BRCA, you're not able to repair DNA damage very effectively in the homologous recombination pathway, and that makes those tumor cells much more dependent on the PARP pathway, a different way of repairing that DNA damage. That makes them much more sensitive to PARP inhibition. Our initial hope had been that since most patients who have triple-negative breast cancer, I said that backwards, that most patients who have a BRCA1 mutation develop triple-negative disease, that there might be a lot of molecular similarities and perhaps many triple-negative breast cancers in patients who did not have mutated BRCA might have a same defect and might have the same response and sensitivity to PARP inhibitors. So far, that just has not seemed to be the case. When we've looked at PARP inhibitors in patients, even with triple-negative disease, but with wild-type BRCA, at least as monotherapy, they have not been very effective. Now, there still may be ways to do that. We may be able to find a small subset that has a homologous recombination defect. We may also need to think about using the PARP inhibitors in combination with the DNA-damaging therapy so that the PARP inhibitors could then amplify the effect of that treatment. And there are studies looking at those possibilities going on now. So I think probably the most exciting thing we saw about triple-negative breast cancer at this meeting is a new compound known as sacituzumab, or IMMU numbers that I don't remember. So this is a new drug. It's an antibody-drug conjugate. The antibody recognizes a trope receptor on the cells. This, as best we know, does not have a critical function. So this is not a driving antibody. This is not like HER2 and HER2 mutated breast cancer, but it's simply a marker receptor protein on the surface of over 90% of triple-negative breast cancers. So that could be useful as a way of targeting the delivery of chemotherapy. So this trope antibody is then conjugated to SN38, active component from irinotecan, as a way of delivering irinotecan more to the tumor cells, less to the rest of the body. And we saw the results of an expanded phase 2 study of that compound at this meeting. Had a quite high response rate, quite long progression-free survival for patients who had been previously treated. So that agent is definitely worth looking for as it moves forward in its development. So So I think it's always difficult to pick a highlight from a meeting. The temptation is to look for the phase 3 trial that will change practice. I'm not sure that we have a phase 3 trial that will really change our practice at this meeting. And picking highlights from phase 1 and 2 studies or early molecular studies is always a bit difficult to predict at this early days where those results might be headed. I think we saw a lot of important results at this meeting that inform our practice, but they probably don't change it. So we learned that adding trastuzumab to patients with lower levels of HER2 expression that would not have been considered for trastuzumab therapy before really was not effective. That was disappointing, but it tested an important question. Had that arbitrary threshold for giving patients trastuzumab been set too high, and might there be patients to benefit who we left out of those original trials? That just wasn't the case, so it won't change practice, but nonetheless an important study. We've also seen increasing data over the years about the importance of bone health and bisphosphonates and now denosumab in the adjuvant therapy of our patients with ER-positive disease. Those initial studies had to pick an arbitrary duration of therapy. So we saw results at this meeting of a trial comparing 2 years of bisphosphonate therapy to 5 years. 5 years was not better. I don't know that we still know the optimal duration, but we do know that going longer did not provide any benefit. And we may see some studies looking in the future at shorter durations of therapy. We also heard the results of the REACT trial, a trial looking at whether inhibiting inflammation by inhibiting COX-2 with celecoxib might also reduce the risk of recurrence and improve outcome. Now, the overall results of that trial were negative, but there's a subset that's worth exploring a bit further. So a subset of patients with hormone-sensitive tumors who did not receive chemotherapy, quite a large subgroup of patients, seemed like there might be a benefit there. Now, they also reported fewer arthralgias. So it's going to take a deep dive in the data to really understand, did they do better because COX-2 inhibition reduced inflammation and that somehow impacted the growth of their tumors? Or did they do better because they had less aromatase inhibitor arthralgias and were able to be more adherent to longer-term hormone therapy? So some interesting results that I think confirm our current practices, but also may point ways forward for us.